So in this video segment, we will be discussing inflammatory diseases of the stomach. This includes acute gastritis, acute peptic ulceration, chronic gastritis, autoimmune gastritis, peptic ulcer disease, and Zollinger-Ellison syndrome. Acute gastritis is a transient mucosal inflammatory process. It can be asymptomatic or result in epigastric pain, nausea, vomiting, or in severe cases, erosion, ulceration, hemorrhage, hematemesis, or bloody stools. So acute gastritis results when the normal defensive mechanisms of the stomach can no longer overcome disruptive forces. These protective factors include mucin secretion by foveolar cells, and the mucus forms a thin layer over the surface of the stomach. Bicarb secretion from surface epithelial cells results in a thin layer of fluid overlying the epithelium that has a neutral pH. Lastly, blood vessels deliver oxygen, nutrients, and bicarb and remove acid. Disruption or direct cellular injury from alcohol, NSAIDs, radiation, or chemotherapy will lead to gastritis. On histology, you will see active inflammation in the form of neutrophils coming above the basement membrane and often in direct contact with epithelial cells. In more severe cases, you can get erosion of the epithelium and hemorrhage. If both ulceration and hemorrhage are present, it'll be called acute erosive hemorrhagic gastritis. Acute peptic ulceration occurs commonly with NSAID or physiological stress. There are three categories of acute ulcers that you should be aware of. The first is stress ulcers. These are typically seen in critically ill patients suffering from shock, sepsis, or severe trauma. The second type are curling ulcers. These are associated with burns and occur in the proximal duodenum. The last type is Cushing ulcers. These arise in patients with intracranial disease and will often be found in the stomach, duodenum, or esophagus. Patients with acute ulcers can present with nausea, vomiting, and coffee ground hematemesis. If bleeding is bad enough, they may require a transfusion. Other complications is ulcer perforation. These ulcers tend to be sharply demarcated, rounded, and small in size with a brown to black ulcer base. Chronic gastritis tends to be more persistent but less severe than acute gastritis, and it just means it's been going on for a longer period of time. The most common cause is infection with Helicobacter pylori. Autoimmune gastritis is the most common cause of atrophic gastritis. Atrophic gastritis is just the endpoint of chronic gastritis, where you get a loss of gastric glandular cells and their eventual replacement by intestinal and fibrous tissues. Other causes of chronic gastritis may include radiation injury, and chronic bile reflux. So as we said, H. pylori is the most common cause of acute gastritis. It is present in almost all patients with duodenal ulcers and most of those with gastric ulcers. It is in 90% of those with chronic gastritis affecting the antrum. H. pylori gastritis can result in peptic ulcer disease of the stomach or duodenum from increased acid secretion. It also confers an increased risk of gastric cancer. So H. pylori infection is associated with poverty, household crowding, limited education, African American or Mexican ethnicity, poor sanitation, birth outside of the U.S. Colonization rates vary greatly, ranging from less than 10% to more than 80% worldwide, and in high prevalent areas, people will typically acquire it as a child. H. pylori has a tropism, meaning it has a predilection for or likes to go to the foveolar cells of the gastric antrum. Its important bacterial virulence factors include flagella motility, urease, which generates ammonia, thus elevating the local pH conditions to protect the bacteria from the acidic pH of the stomach, It also has adhesions, which help adherence to the cells, and also produces toxins like Kag, which may be involved in ulcer or cancer development. These virulence factors result in an environment in which the destructive forces win out over the normal protective defenses. Over time, chronic H. pylori antral gastritis can progress to a pangastritis, resulting in multifocal atrophic gastritis. So H. pylori gastritis can be diagnosed in several ways, including antral biopsy, fecal bacterial detection, serum H. pylori antibodies, or the urea breath test. On biopsy, you can often visualize these spiral-shaped organisms, and they can be highlighted with the Wharton starry silver stain. Neutrophils are seen infiltrating the lamina propria or even in mucosa-associated lymphoid tissue composed of lymphoid aggregates can be induced, and these have the potential to transform into a lymphoma. The presence of intestinal metaplasia is associated with an increased risk of cancer. In terms of the clinical features, patients with acute gastritis will often have high acid production despite low gastrin levels. The patient often experiences nausea, ab pain, and vomiting. Treatment is with a proton pump inhibitor, such as lansoprazole, and antibiotics. You can use either clarithromycin plus amoxicillin or amoxicillin, metronidazole, and clarithromycin. The second most common cause of chronic gastritis is autoimmune gastritis, and accounts for less than 10% of cases. The median age at diagnosis is 60, and it is associated with other autoimmune diseases, including autoimmune thyroiditis, diabetes mellitus, and Graves. Autoimmune gastritis results from loss of parietal cells, which normally secrete acid and intrinsic factor. This defective gastric acid secretion, known as achlorhydria, results in hypergastrinemia and hyperplasia of gastrin-producing G cells in the antrum. Remember back to physiology that gastrin secretion is normally inhibited by acid production. This is one way that autoimmune gastritis can be differentiated from H. pylori gastritis. Also, unlike H. pylori gastritis, autoimmune gastritis spares the antrum. Patients also will have antibodies to parietal cells and intrinsic factor. Remember that intrinsic factor is needed for B12 to be absorbed, so loss of intrinsic factor leads to B12 deficiency and a pernicious anemia. Chief cells are also lost, leading to decreased pepsinogen 1 levels. On gross examination of the stomach, you can observe diffuse damage to the mucosa of the body and fundus where oxyntic or acid-producing cells are located. You can also see diffuse atrophy with loss of rugal folds. On histology, inflammatory infiltrates are seen primarily lymphocytes and macrophages. Parietal and chief cell loss and intestinal metaplasia can also be present. So go ahead and take a moment to construct a table comparing and contrasting H. pylori gastritis and autoimmune gastritis in terms of the inflammatory infiltrate that's present, the amount of acid production, the gastrin levels, what serology is seen, clinical features, and any associations. So in comparing the two, H. pylori gastritis, you're going to find neutrophils and plasma cells, whereas in autoimmune gastritis, it'll be lymphocytes and macrophages at the primary infiltrate. In H. pylori gastritis, acid production will be increased or slightly decreased, whereas in autoimmune gastritis, it's going to be decreased. Gastrin levels in H. pylori are normal to decreased, whereas in autoimmune, they are increased. On serology, you're going to have antibodies to H. pylori in H. pylori gastritis, whereas in autoimmune gastritis, you'll have antibodies to the parietal cells and intrinsic factor. Clinical features of H. pylori are peptic ulcers, carcinoma, and lymphoma. In autoimmune gastritis, you're going to see atrophy, megaloblastic anemia, and carcinoma. H. pylori is associated with low socioeconomic status and rural areas. Autoimmune gastritis, however, is associated with other autoimmune diseases. So now we'll talk about peptic ulcer disease, or PUD. This typically occurs in middle-aged or older adults with chronic gastritis. 70% of cases of PUD are associated with H. pylori, making it the most common cause of PUD. However, only 5% of those infected with H. pylori will eventually develop ulcers. PUD is also commonly associated with NSAID use. PUD of the esophagus can be caused by GERD or acid secretion by ectopic gastric mucosa. In the small intestine, PUD can be a result of gastric heterotopia within a Meckel's diverticulum, which we'll talk about in a different lecture. PUD typically develops in a background of chronic gastritis due to damaging forces overcoming the protective defenses. Cofactors in ulcerogenesis include NSAID use, cigarette smoking, and corticosteroids. It's also associated with alcoholic cirrhosis, COPD, chronic renal failure, and hyperparathyroidism, and psychological stress. So peptic ulcers are most commonly found in the proximal duodenum. They're actually 4 times more likely to be found there than in the antrum. But within the stomach, peptic ulcers tend to be located at the interface of the body and antrum. Grossly, they're going to be seen as a solitary and sharp punched out defect with a clean ulcer base, as seen in the top picture on the right. And then on histology, you're going to get granulation tissue at the ulcer base. So in the slide, you can see the layer of cellular debris followed by fibrinoid necrosis and then your granulation tissue. Patients presenting with PUD typically have a history of chronic gastritis. They will have epigastric burning or aching pain that's going to be worse 1 to 3 hours after eating. The pain also tends to be worse during the night and will be relieved by food or alkali, like Pepto-Bismol. Patients can also have iron deficiency anemia from ulcer bleeding. More severe complications are going to be hemorrhage or perforation. Treatment is typically with PPI and antibiotics for the H. pylori. Surgery is required in the case of perforation or bleeding. So Zollinger-Ellison syndrome is characterized by multiple peptic ulcerations in the duodenum, stomach, and jejunum. This is from a gastrin-producing tumor of the pancreas or small bowel that results in massive acid production. Patients can have chronic diarrhea or steatorrhea in addition to symptoms of PUD. And 25% of those with gastrinomas will actually have multiple tumors as part of the MEN1 syndrome. Remember, MEN1 is going to be your 3 Ps: pituitary, parathyroid, and pancreas. And in the case of pancreas, it's your gastrinoma, leading to extensive peptic ulcers.